Everybody okay if we get started?
Yes, please.
Okay, so we're going to get started. I will do what little housekeeping I can do. Has everybody reviewed the minutes from October? Motion to accept the minutes? Okay. All in favor? Any opposed? Okay. So, a little bit out of order today, since we have everyone here for stroke. We're going to move ahead with that first. I have an issue that I need to take care of, so Heidi will finish up the meeting for me and do the rest of the housekeeping after we're done stroke discussion. So with that, Mike?
Sure, thank you. Before we get started, we have some guests in the room. Let's go around the room really quickly, just so everybody knows who's represented here from the hospital side, and the rest of us know who's represented from the hospital. So,
I'm Dr. Colin Amory from Albany Medical Center, Director of Stroke.
Adrienne Weitzel from Albany Medical Center, the stroke coordinator.
Kristen Manalpin, Albany Med, stroke quality specialist.
Julia DeFabio, Albany Med, stroke educator.
Frank Stanger, emergency physician, Columbia Memorial. Dr. Yuri Stipa, Columbia Memorial Hospital, Greenport Rescue Squad.
Not a doctor. Greg Fox, Greenport Rescue Squad, Columbia County Deputy EMS Coordinator.
Dean Mono, Rotterdam EMS, and I paramedic.
Jay Tyler, Director of EMS Operations, Town of Gilbert.
Margie Panetta from Ellis Hospital Stroke Program Director.
Dr. Don Doy now, St. Peter's Hospital, Albany County Sheriff's and Gilbert.
I'm supposed to be Dr. Brooks from Ellis Medicine, but I'm Bill Owens, the neuro PA.
Much better looking.
Walter Group, Colony EMS.
David Sorrow, Schenectady Fire.
Stan Wogaki, Schenectady Fire.
Jump back to Bruce.
Dr. Stephen Hess.
Go ahead, Bruce. You're late.
Okay. Hi, Bruce Eshkow from St. Peter's and various assorted EMS agencies.
Jeff Williams from Mohawk Ambulance.
Carol Brandt, Mohawk Ambulance.
Mary Ramos, State Department.
Alan Bell, Executive Director, Clifton Park Ambulance.
Sean Wogaki, Assistant Director of the EMS Operations, Town of Frank Denise, Chief ED at St. Peter's.
Scott Skinner, Executive Director, Multi-Store EMS. Stephen Hess, ER physician, Albany Med, EMS Director for several agencies.
Dr. Heidi Cordy, also EMS Division, AMC, and et cetera, EMS Medical Director.
Tim Raleigh is Executive Director here at REMO.
Yes. Ron McHugh, LCD Director and REMAC Chair.
Beth McGowan, ARMS Representative to REMAC and AMR.
Mike Daly, Regional EMS Medical Director. So, thanks. Thank you for joining us. Appreciate that a lot. I wanted to start with a little bit of the why we're having the discussion first. The slides I'm going to show you actually are from a guy named Chris Zammit. Chris was a medical director of the stroke unit at University of Rochester. He has since moved to Cincinnati, but the STAR program that he started in Rochester continues, and continues very successfully. This data was also supported by the Northeastern Cerebrovascular Consortium, who currently is going to be supporting our stroke program here regionally as well. The reason that we're talking about this, the efficacy of mechanical thrombectomy, very well demonstrated in both DAWN and the Hermes trials. What these definitely showed is that the faster we do intervention, the better the patient does. It just makes sense, and now we actually have the information to say that. In their region out in Rochester, their times for mechanical thrombectomy were pretty long, very long in fact, and these were just some of the basics, basic times before they started their trial. And that was really important. The times were terrible, and that's why I thought it was important to bring this here and have a little bit of a conversation about it. They looked at some of the information that was created in Rhode Island and realized that Rhode Island was actually very representative of what they were doing in Rochester, because you can actually see here Rhode Island superimposed on top of Western New York, just for entertainment's sake. Monroe County is actually much, much larger than Rhode Island. We obviously serve 6 counties here, including our ancillary counties. Beth will say that you're representing the ancillary counties today. That's right. What they did in terms of a pathway out in the Rochester area is mainly hospital-based, but it was rapid identification of potential large vessel occlusion strokes that had the potential for mechanical thrombectomy. They wanted, as did we, when we started our stroke program here regionally, to make sure that patients that can and are appropriate for remaining in their community hospitals do so. If there is no benefit for a transfer to a comprehensive stroke center, please don't send the patient to the comprehensive stroke center. If there's benefit from the patient being at the comprehensive stroke center, please make sure they get there as soon as possible. This is the way that we're doing it. Patient gets to the outside hospital, they have stroke symptoms, last known well of less than 24 hours. They do an NIH stroke score. That score is greater than 3. The patient gets a non-contrast CT and a CT angiogram with immediate upload. The other thing they did in parallel to that is, as soon as they identified a severe stroke, so an NIH stroke of greater than 10, they did all that same stuff, except they started the transport process at the time of identification of that stroke. These patients were immediately accepted without question by the comprehensive center, so all of the processes to move that patient were ongoing at the time of the original diagnosis with the stroke score. This is basically their process internally. And what they did then is start to look at the data and how it really worked out for them. This data was what was transmitted to the Comprehensive Stroke Center, so the stroke center would be ready to take care of the patient and make sure that they had the ability to follow through and get additional information, like the contact name of the person that we frequently lose. This is the piece that was most remarkable to me. If you look, there are 3 hospitals with 3 very different abilities or processes in terms of integrating their code LVO system. Initially, all of these, the door-in, door-out time, the time the patient remains stuck in the hospital that they originally went to, was greater than 2 hours, which is really reflective, to no small part, in what we have now. It's really hard to get a patient out of a hospital. Hospitals have this magnetism for patients, right? After they instituted the code LVO, these absolute differences in time are real. So that hospital number 3 is remarkable. They dropped their time literally by 1 hour and 10 minutes. That's amazing. And then the most important thing is that the mortality rate dropped significantly by 10% for these patients with these huge strokes, and the thrombectomy attempt rate went up by 30% because there was still viable brain when the patient arrived at the comprehensive center. And frankly, I think that there's no reason that we can't replicate this data here. We can get patients moving faster. This is what it looked like compared to the rest of the state. Their median door-in, door-out time when they started this trial was exactly the same as New York State's. Now they are much, much faster, and their door-in, door-out times of less than 60 minutes, which is really where I think we set our goal, right? Because we want those patients moving as fast as physically possible. They did a fantastic job of getting them less than 60 minutes. So they had lots and lots of thank yous to people and their whole team, but bottom line is they focused on it, they measured it, and they improved. And I think we can really do the same sort of thing. So with that, I'm going to start throwing it.
Yeah, just to go and put up the...
You can look at some of the local work here. Just an idea on where some of our times are, if you want to talk to them while I go.
Yeah, but why don't we talk about our numbers here first, and then we
Yep.
can. Let's just go.
So we have our pre-notification, and some of these slides are just A and C.
Yeah, so where did we get the data from, first of all?
So this data that we're gonna show comes from our registry, so all of our patients that fall into our stroke metrics and discharge will go into our registry, and this is where we're getting our reports from. So it's called IQ data, to get with the guidelines. So if we look at this, and some of this we're actually talking with our abstractors because we're trying to figure out if they're missing things, because we do feel like these numbers should be a little bit higher.
For sure.
But as you can see, over 50%, at least 50% or greater of the time, we are getting pre-notification by EMS, which is great. We, certainly want to hopefully get that up 100% of the time. I'm confident that we're higher than these numbers, so we're just going to continue to work with our abstractors to make sure that they're getting the information, and now that some of the stuff's coming in electronically, I think our abstractors will be able to find this information.
Remember, these are people looking for information on the PCRs, and if the PCR isn't there, we can't find it. And if it's buried in a narrative someplace instead of being someplace very concrete, they can't find it either. This is something that's Syracuse, for example, the Syracuse region had 100% compliance with this because they were all using one data system and told everybody exactly where to put it, and then all of a sudden they could find it. We've never actually had it as concrete, and as a result, we can't find it.
Does that also include the data from interfacility transfers coming from community hospitals?
Yeah, that was just Albany Medical Centers there.
So
Right.
that's
So, yes.
anybody who comes to us by EMS, wherever they came from.
Whether it's 911 or interfacility.
Exactly.
This is just to show Albany, again, a lot of these are Albany Med specific because I can't pull other hospitals. Just to kind of show, out of all of our patients, about 50% of our patients come from transfers, and the majority of the rest of them are coming EMS direct from the field. We have like a handful of patients that come in through our walk-in triage, so our patients are definitely, more than half our patients are coming EMS, either from transfer or direct from that.
Well, nearly 100% are coming from EMS,
Well,
right?
right,
You know,
sure,
in
yeah.
one form or another. Some of them are coming directly from home via EMS, and some of them are coming from other hospitals via EMS. So clearly, this is, we're in the right forum.
So this slide is what Dr. Daly was speaking to. So the one thing I could pull was the door in, door out times from the first hospital until they get to Albany Medical Center. And as you can see, every quarter this year, we're over 61 minutes, so over an hour to get into a hospital, then to get out, and then to get to us. So.
And we don't have breakdown beyond that, right, as to if it's over 2 hours or in between 1 and 2 hours. But as Dr. Daly said, I think our goal, we want it to be that the door in, door out time is 60 minutes or less for our transferring hospitals. Especially if the patient's getting TPA, obviously you have a door to needle of 60 minutes or less. So that should be your goal, get the TPA going, and then in an ambulance to come to us if that's an appropriate transfer to come to the Comprehensive Stroke Center.
And then, since we do have the endovascular therapy, we just wanted to show, we were able to pull time from arrival at referring hospital to endovascular therapy at Albany Medical Center. And again, most of our times are over that, what is it, 181?
Yeah, 3 hours.
Yep. So, again, a lot of our transfers, they get to the hospital great, and then there's just some sort of lag to get them back out, so.
Yeah.
So it's our goal with the next grant is to actually physically move this entire graph to the left.
Yeah.
Because we can do that.
Well, and you can see, we had one that was in between the 1.5 and 2 hour mark. That's a great outcome, right? That's somebody who really, everything worked reasonably well. So it's doable.
And then this is times from first medical contact to endovascular therapy. So you can see where we are kind of moving it back this way, but these are the direct presenters from EMS. So the ones that come right to us, they don't go to another hospital.
That's it.
Let's look at the data.
State of the data that we are dealing with currently. and sort of a snapshot of what we want to try and change through our interactions with our referring hospitals and with EMS. All partners together on this.
So the one thing I would add to that is that we sent out a stroke advisory in February that asked for everybody to be using the FAST-ED. The FAST-ED, unfortunately, is showing up on somewhere around 15 or 20% of our patients that actually are diagnosed with stroke, as we look through the data primarily. Some ambulance agencies are doing a fantastic job with it. Some it's really not appearing there at all. So what we're going to do is an educational push directly to the providers and ask you to support it for the next 3 or 4 months to really push hard to use that FAST-ED, because for those patients that have the FAST-ED score of greater than 3, that's where we're looking at the NIHS stroke score of greater than 6 or 8, and that's where it starts to become so much more important for those patients to have the potential for endovascular rescue. I wanted to be able to say what our percentages were for FAST-ED scores and endovascular therapy. We just don't have enough data because EMS hasn't collected that for us yet at this point.
Well, I'll say, or we haven't been able to find it, right? To be
I've
honest,
gone back on a bunch of them, and
yeah,
it's
they're not there.
a lot.
Okay, fair.
Mike, have your EMS stroke volumes changed in the last year? Are you getting more strokes compared to last year?
Probably about, I just did the numbers 3 days ago,
Okay.
so maybe about 80 to 100 more patients this year. We're definitely getting more ischemic strokes, acute
Yes.
ischemic strokes than we are TIAs, and even ICHs are down. Subarachnoids are literally one off from each other, but definitely more acute ischemic strokes, which is good. That's what we want
Right.
at the comprehensive center, and the TIAs have kind of dropped off.
And if you look back over the past 4 years, there's definitely been a trend of increase of transfers of ischemic strokes to Albany Medical Center. It makes perfect sense. Ever since the thrombectomy data came out in 2015, and the comprehensive stroke center needed to be a big piece of regional stroke care, we've seen an increase in transfers to us.
So I was gonna, some of the data is being represented, I'll do that very quickly, but I'm Alan Willis, one of the neurosurgical doctors. There's 4 of us that do the endovascular procedures, and it's a 24/7 shop. The issue is, as you guys have seen me present this before, but this is the large vessel occlusion that Netter drew, which is more like a coronary problem, plaque rupture with occlusion. But the truth is, with stroke, we have all of these different etiologies, and that's what makes these more difficult, more challenging to figure out. Why FAST-ED or any clinical exam can't quite be perfect in determining when you have a large vessel occlusion. Having said that, it's the best we have at the time, and a large vessel occlusion is a game changer in terms of what we can do now to help these patients. The number needed to treat is less than 3, which is remarkable. And so we want to get as many of those patients to the place of care that we can within the quickest window. These are the slides that are repeated, so I'm not even going to talk about it. I'll just skip through them, but they've just been presented. And then this is what was just mentioned about the FAST-ED. What we see in the EMS, it's 13% the last quarter. This is all strokes that are documented as such. Dr. Ali Paul, who's one of my partners, she went through the first 3 quarters with the help of the stroke coordinators to look at those who actually got mechanical thrombectomy. So at Albany Med, we've done 78 with the first 3 quarters. That would annualize to maybe 110. There are 5 inpatients, 3 walk-ins, so it didn't come through EMS, but actually came through the ER directly. 32 EMS direct, 38 EMS from outside hospital, and 5 LifeNet. So that's the demographics of the population that came. What is clear is that the FAST-ED score was in about 37% of those patients, so that's higher than the number I gave you for all comers. And I think it does, well, we don't know. Maybe FAST-ED was used when the stroke was more apparent to be a severe one, so it was documented. Or maybe when you do the FAST-ED, you kind of can categorize them to the comprehensive stroke center quicker, and they're getting their care there faster. We have had cases of direct cases where EMS is bringing them from fairly far out, which is good to see. Most likely, again, it's a sign that the FAST-CD score or some surrogate marker is actually working, that EMS is bypassing in the cases where large vessel occlusion is suspected and going to the comprehensive stroke center, which would help reduce our time to treatment and I think improve outcomes. When you look at this, the median transfer distance, direct 13.2 miles versus 47.3 miles from the transfers. Now the transfers, most likely, not in all cases, but in a much higher number, we will know that they have a large vessel occlusion. The outside hospital has ascertained that and is sending it for that reason. And you can see we're still in the 30-something% for treatment because the length of time to get to the comprehensive stroke center remains an issue, so that our number of cases that can actually be viably treated is still low. So we want to work on that. That's what the last presentation was all about, was how to improve those times so that we can make more of those patients better with this treatment. This is, again, only the thrombectomy patients, and it gives you a sense of where they're coming from, which is not surprising. It follows the demographics, I think, for stroke. Here, these are anecdotes, so I don't want to overemphasize that somehow we know all the results, but you can see for the abstractors it's pretty difficult. They have to find the actual words, positive Cincinnati finding. But in fact, here they defined the FAST-ED with a left facial droop, flaccid on the left side, last seen normal last night at approximately 9 p.m. Now this one, a little frustrating for me to read because it suggested that they wanted to take it to the primary stroke center and that the family requested to go to Albany Med. And I think this would have been a high FAST-ED score, and again, last seen normal 9 p.m. the night before, so likely wasn't an IV-TPA candidate. So here, this would have been a good one to drive to the comprehensive stroke center because there wasn't much to offer at the primary stroke center acutely. And if a good candidate with large vessel occlusion, which he did have, would be a good candidate for thrombectomy potentially. So that's where this scale can be really a great driver for getting the patients where they need to be. And part of the scale includes last well known, so that would be incorporated within it. Here's another one where FAST-ED is clearly delineated, 5, which is high, which suggests would be a good candidate for, high likelihood of LVO and a good candidate. This one also has the etiology with rapid AFib on the left, or your left. Here's a couple examples. An 82-year-old gentleman who presents with sudden onset of right-sided weakness, aphasia, and a stroke scale of 13. This is the dictation. Here, the wife initially wanted to go to the primary stroke center, but because of the severity of the stroke, the FAST-ED score, agreed to go to a comprehensive stroke center 10 miles away. EMS arrived at 6:07 in the morning. We were able to do the procedure. Here's the left middle cerebral artery. This is where it divides, and there's an occlusion of its major trunk as it exits. This one branch is open, the second branch is closed. After treatment, now you have the branch is now wide open and supplying this lateral surface of the brain. And this dramatically improves the patient. So this is called the TK3 when the reperfusion is full. And it's 156 minutes from EMS arrival at the scene to reperfusion, to fully reopen. So they've been evaluated in the field, brought to Albany Med, gone through the imaging sequence, gotten to the groin puncture, and had the procedure done. And still, there's probably room for improvement. I won't dispute that, but at least we're getting to the point where we're helping patients with this direct line for when there's a clear evidence with the FAST-ED score being high. Small DWI changes, which is fairly common. These are small strokes, but they don't result in significant disability, fortunately. A second case, a younger patient, a 57-year-old male, last seen normal at 2300 the night before, presents with left-sided neglect, left-sided weakness, and a right gaze. 12.2 miles from Albany Med, but again, the FAST-ED score of 4, direct to Albany Med for interventional consideration. Here again, we have a right MCA occlusion right at the opening of the right middle cerebral artery. If you can see that here. This is the anterior cerebral artery. The middle cerebral artery is included at the base. The procedure is performed with the reopening of the artery. A full reperfusion, and we're done at 1:42 in the morning, which is, I think, Well, he was last well known at 11:30, so within 3 hours has been revascularized. So again, there's still always room for improvement looking at these numbers, but I do think this is working when the FAST-TD score shows a high number and there's a good opportunity to get the patient treated quickly. Here are some of our numbers. This is a bit different data. This is related to the endovascular treatment. And this is again through the abstractors and American Heart. Door to puncture time within 90 minutes. We are the red line, which is Albany Med, and then we're being compared to, it's cut off, but we're being compared to either academic medical centers, New York State hospitals is the yellow, or all comprehensive stroke centers throughout the country. And we compare fairly favorably from the door, which is our door, Albany Med's arrival, to getting the puncture started. I would still argue we could do better, but at least the percentages are high that we're making it within 90 minutes compared to national averages. Picture to puncture, this is from the CT perfusion to puncture, and again, we're the red line. We're doing pretty well with that, getting the patients to the angio suite right after the CAT scan is performed within 60 minutes. Here we don't do as well. Now this is a different dynamic. This is arriving at our door to starting the revascularization procedure within 60 minutes for the direct transfers, or 90 minutes if you present directly. And I showed you the 90-minute data was good. So the problem for us is that we continue to use the same algorithm when you're a transfer or when you're a direct admission. So if you're a transfer, we still want to get the CT perfusion on arrival because that transfer time can be so long, and we need to know that the patient's still a good candidate for the treatment. And so we have not been able to move the needle as well with this statistic, and I think that largely rests with the fact that our transfer algorithm is the same as with our new arrival algorithm. And we're reviewing that to see if that's really the best strategy. We're building a new biplane suite that should allow us to do perfusion on the table, so that might be a way to skip the CT scan when they arrive with a known large vessel occlusion. Maybe we can go straight to the angio suite, do the perfusion on this new angio suite table, and then proceed if it's appropriate.
Just so you guys know, what the perfusion scan shows is the area of the brain that's still viable in spite of the fact that it's not getting direct blood flow. And that's really important, because if the stroke is completed, taking the clot out doesn't make as much of a difference. If, on the other hand, the stroke is not yet completed and there's this viable tissue remaining, that's what will make the biggest difference for the patient. That perfusion scan is ridiculously expensive technology and very, very cool. Very cool.
But it was also a game changer. The trials that were finally positive required that perfusion imaging initially. And now since then, more and more literature is starting to argue maybe skip the perfusion and just treat everybody with this technology and accept that some patients won't get better, but at least you've treated everybody. But that's still a controversial statement, but it's being considered in the neurosciences at the major meetings. The last two slides are here, which is door to reperfusion within 120 minutes. So this is a TICI 2B or 3, which means the endovascular treatment was successful. You're able to reopen the majority of the vessel. And we've done fairly well on this. We're the red line again. We've had a down month in February, but the majority of the months were even with the national or higher than the national averages. And then here, the rate of substantial reperfusion, which is at the end of the procedure where you TICI 2B or 3, which means the majority of the flow was restored. And again, we do at least within the national average or slightly better on a few months. So, so ultimately, it's a promising tool. It's a promising technology. It's all about the speed to get to the procedure, as the cardiologists have showed us in the heart. And we're making, I think, good progress. We have more to do in terms of how we triage through EMS and getting some kind of clinical skills widely adopted so we can make the right decisions at the right time.
Awesome. Thank you.
Questions or thoughts?
The only question I would have being at St. Peter's, if they have a high score on the FAST-TD, do you want us to get the CT angios, which waste time, or do you want us just to call and get the transfer down to you without any scans?
My approach has always been, if you call me with a case that sounds like it's going to be a large vessel occlusion, I don't want you to get a CT angiogram. Because the chances are, you know, if it's a high NIH stroke scale, high FAST-ED, whatever scale you want to use, there really is going to be a large vessel occlusion, and then transfer them and don't waste the time sending them back to the imaging. Now, if you have somebody with a stroke scale of 2, FAST-ED score of 1, you know, and you're trying to decide about transfer, I may say to you, well, this doesn't really sound like it's going to be a large vessel occlusion. Why don't you investigate it yourself? And if you find something, we'll take them. You know, I think we could. There have been times when we found patients who have a very low stroke scale with a complete MCA occlusion. Certainly, it happens. You know, I don't know. What do you think, Alan?
No, I agree. I mean, I can tell you, it took us a long time at Albany Med, but I firmly believe that if you're calling me and are considering a CTA, then you should be sending the patient. Because we went after much effort to get to the point where now when a patient with a stroke comes in, they get all that imaging done right away. There isn't this CAT scan, then go back, do a CT perfusion, because that's an hour, in my opinion, at least of delay to get the patient back on the scanner, get the patient back off the scanner. So if you've done the CAT scan and you know there's no hemorrhage, then at that point you're deciding whether to transfer or not. But to go back to do a CTA, that's an unnecessary hour.
I agree.
Anything else new on the horizon from your guys' perspective?
I mean, I think there's two things that are interesting. I didn't show slides on it, but it's stuff we're working on. So within endovascular treatment, there's been an evolution in the technology further from what gave us these positive trials. And so that's partly why we see some 100% recanalizations and reperfusions, because the SAVE technique is a new technique that we're now using. There's a new, couple new devices around suction that work more effectively than before. And then the other aspect, which I know it's not within our realm, but I think could also expedite processes, is tenecteplase or some other clot-busting drug now that's bolus delivery that can speed. I know the drips are acceptable in the ambulance, but if you don't need a drip to be in the ambulance, it's probably even better. So if you can give a bolus and send them, and the effectiveness is as good, maybe better, that could also expedite processes.
I agree. So the tenecteplase is the thing that I think we need to talk about with our referring hospitals. So this is a single dose bolus without an infusion following that a major trial called Extend-IA showed equivalence to TPA for improvement, and in fact might be more effective because of that decrease in time spent in the outside emergency department for transfer, just because you don't have to worry about the hour-long infusion following the bolus.
How does it constantly reconstituted like a CPA?
I think it is. I think it is. It's been a long time.
It's a weight-based dosing.
It is weight-based, but I'm
But it's not draw, you still have to mix it up.
Yes, you still have to mix it up.
What was the functional outcome of those cases? A good angiographic outcomes, but what was how do they do?
The clinical outcomes are around 60 to 70%. So there's still not everybody gets better, but this is all comers. So if you reopen 80, 85.
But they've already failed TPA at that point anyway. If they got TPA.
Right. I mean, I'm not sure you can say. Yeah. I mean, that's to say the TPA did not open the blood vessel up. That is correct.
Yeah.
But a fair number now are not TPA candidates for whatever reason.
Yes, so we got nothing.
But, yeah, exactly. So, you know, if you look back at the original trials and the meta-analysis, which is the Hermes trial, that looked at all the data together, you know, you were improving the rate of excellent outcome from somewhere around 25 to 50, basically, somewhere around there. And that's, for this degree of stroke, which has long been considered to have a mortality rate of around 80%, you know, that's a huge, huge difference maker.
Yeah, I mean, the clinical benefits have gotten higher and higher. Now, the Australian randomized trial was 65%, 70%.
So I do want to say that if we can get the FAST-ED scores on a meaningful percentage of the patients who come to us, we can come back to this group and do an analysis of how effective our cutoff point is for making decisions around transfers. you know, how, you know, we already know that the FAST-ED score, like all of these large vessel occlusion scores, is a reasonable choice. It's not the greatest or the most perfect thing in the world, but it's what we have, and it's one of the best ones I think available. But I think it'll be useful to come back to you guys and say, this is what we found based on the FAST-ED scores that you guys have been telling us. And then I think that's a nice opportunity.
I guess the other thing to discuss is the Join app.
Sure.
And Colony EMS is on it, and when they, so the Join app is this app that is made by a company that gives an app for FAST-ED, so you can, on the phone, determine the FAST-ED score, and then that will go to the Join app, which will then give you a map of the primary and comprehensive stroke centers, and depending on the score detail, whether you go to the closer primary stroke center or the comprehensive stroke center. And in that process, we also get, anyone who's on that app, which is the neurologic team at Albany Med, will see the score and the time of the score, so that we'll have forewarning about a FAST-ED number, and we won't know when you're coming necessarily, but an estimate around that. So that could be also useful, particularly in the app for FAST-ED goes through each question, so it makes it a little user-friendly to determine the score.
Thank you.
Questions? Thoughts from, I know Ellis is here. Anybody else here? Oh.
Well, he's just one of us. He's not.
Yeah.
I do have a question.
Yeah.
Or I'm looking for clarification. I was told that when we send somebody for potential intervention, that they have to go through the ER first. They don't go direct to any suite, angio suite, or they do have to go through the ER.
That's correct.
Everything for Albany Med goes to the ER. Same thing for cardiac and.
Yeah, at this point in time, our protocol is most easily managed by having them come through the emergency department. Certainly if, you know, this new table is proved to be effective, you know, we could talk about it, change that protocol, but.
Yeah, so I mean.
What's that?
They'll always get eyes laid on them by the physician.
Well, it's, you know, I think that's important. The question, I think, that will be answered most with the new table, which sounds ridiculously cool, will be how much faster we can do that door to needle, right? The door to puncture. Having them come to the ED first, get registered in the ED, and then move on to other places is exactly what we do at STEMI. So those STEMIs coming in from the field pick up their packet at the door and then go straight upstairs. And if this table pans out and you're sending us a known LVO, that's exactly what we would do. In the meantime, we're working with the systems that we have in place. So they come in the door, goal would be straight into a perfusion, straight from the perfusion down the hall.
And I think the other aspect of it is what Alan mentioned before, is that if we can diminish the door in, door out times at the other hospitals who are referring to us, I think we'll feel a lot more comfortable of moving them more quickly through the process.
Yeah, sure. I mean, the candidacy of the patient's likelihood of getting better is dramatically different.
Yeah.
And whether you need to repeat the imaging would go down, as we know that the time between the two is shorter.
Yeah.
So no CTA.
For patients that don't, I'm sorry.
No, that's good.
That don't require intervention after imaging and so forth, are any of them sent back? Because we don't know, because of our transfer center, we might not even see those patients get in the ED. Does anybody get?
Right, if a patient, so if a patient comes to us as a transfer from ED to ED, we can't transfer back, as you guys probably know, because of EMTALA rules.
Right.
If there's a patient who was direct transferred to us, and we managed the acute manage, or didn't even go through the local hospital, just came directly to us, and the family says we'd like to move to a hospital that's closer to us, we can certainly discuss that option, but most of the time, that's a challenge to get accomplished.
Yeah.
In my
No,
experience.
there were discussions in the past about sort of repatriation.
Right.
Yeah, that was partially because of not getting bombarded.
Well,
bombarded in the ED. You
no,
know,
Frank,
I'm talking about.
yeah, we had done some repatriation.
Yeah.
Some of it has happened, it actually gets very complicated to manage those moving pieces. The most important thing to make sure within EMTALA that we're not going to a lower level of care for a patient that may need something higher. But we've had some successful repatriations in terms of being able to do it on a systematic basis. It has to be case by case and very clearly delineated. And again, not ED to ED, but ED to service at an outside hospital is something that's very reasonable to consider, but maybe something that's a little easier to talk about than it is sometimes to implement.
When I see people in the ER, I usually go with them to CT and examine them on the table. And if I feel it's indicated, then I'll do a CT angiogram right there. But if you're, what I'm taking from this is if you feel my score is high enough that we're gonna transfer, should I just start the process and not wait for the phone call back from the transfer center? Because the quagmire in our emergency room is that the nurse taking care of the patient has to call the ambulance. Well, she's busy taking care of the patient.
Right.
So there's another 20 minutes before she can get on the phone to call the ambulance and all those minutes just keep adding up. And if I'm waiting 20 minutes, wait, transfer center, you guys are pretty quick calling back.
We try. But I would say, yes, just get things rolling. You know, if you really think this is gonna be, I mean, if you call me up and tell me you've got a patient, you know, the stroke scale of 10, I'm just gonna say send the patient.
You've never said no.
I've never said no, right? So, let's just go ahead and get it started as soon as you can. Absolutely, I agree.
So what we implemented it with folks at Northeast partners, is they have a designated person that calls. It can be their unit secretary, and they call right away. As soon as the decision's made, they've identified who's going to make the call, so there's not, oh, I thought you called, oh, I thought you were going to call, kind of thing. And they call with a code stroke in this case. They do it for STEMIs also, and it indicates to our folks, and they call it in as an emergency, so they come right away and treat it as an emergency. So you might want to maybe look at how it flows through the ED, and not wait for the nurse to have to call, but call right away and have the ambulance rather sit there and wait for the patient than
of course
than be running late.
Yeah.
So this we did. We came up with the whole flow chart for them for the staff in the ED so that they kind of know how it would operate, and the same thing in our dispatch center. So
I think what all of you are highlighting right now is exactly what they did with that code LVO out at University of Rochester, right? So the call that you make saying, hey, listen, please tell Dr. Amory I've got a guy with a stroke score of 10 on the table who's getting their regular head CT right now. That doesn't even need Dr. Amory to call back. It's an auto accept, and at the same time, it launches an ambulance.
For these LVO thoughts, you don't even need a call back from me. And it's just, you say that's what it is, they come. We can talk about doing that too.
Neurosurgeon's been auto accept for years.
I know you have.
But we still get the calls because sometimes there's a question, so it's fine.
Exactly.
But
No, I always happen to
but it shouldn't be a detriment to the pathway, that's the key. It shouldn't be,
Give us a couple weeks on that.
Okay. Good.
I think that was great.
Thank you very much for that.
Thank you.